A team of undergraduate engineering students at the University of Virginia has developed a tool that helps with one of the most common problems brought to pediatricians.
Fluid in the middle ear of children is the #1 diagnosis that children present to pediatricians, family medicine doctors, and emergency rooms across the country. When children have ear infections, they're fussy, they don't sleep well, sometimes they have fever, and they can have an associated hearing loss because of fluid in the middle ear space.
Acute infections are treated with antibiotics. If fluid persists, ventilation tubes may be inserted.
Ventilation tube insertion is probably the most common procedure performed in the United States today, perhaps other than circumcision. The operation is fairly straightforward. We make an incision in the eardrum, we remove the fluid from the middle ear space, and we insert a grommet, a little tube that is situated in the tympanic membrane. Part of it is in the ear canal, part of it is in the middle ear, and the purpose of the tube is to aerate or ventilate the middle ear space to prevent fluid from reaccumulating. The more times that you put an instrument in and out of the ear canal, the greater the risk for damage to surrounding structures. The surrounding structures would be the wall of the ear canal or even the tympanic membrane. The skin of the ear canal is some of the thinnest skin in all of the body. So one tiny little touch on this skin and it starts to bleed. If you have bleeding in the ear canal, and this procedure is done under a microscope, you can't see anything. So then you have to remove the blood and you have to get a clear surgical field before you can safely put the tube in.
Shayn Peirce-Cottler, assistant professor in UVA's Department of Biomedical Engineering, explains how the new ear tube insertion device significantly decreases the time in surgery.
We've basically reduced the procedure to needing to make the incision first with a myringotomy blade, so we didn't incorporate that aspect. But then, in one fell swoop, using our device, we can insert the ear tube, provide the suction, both before and after, and seat the ear tube into the incision site, just with one pass. So it basically cuts the total procedure time down by half, and this is what we've validated in small animal testing as well as currently now in our clinical trial.
But the tool was not the team's only successful creation. The students also built a model of an anatomically exact ear so they could practice the procedure.
Once we designed the ear tube insertion device, we had to test it. We can't test it on humans, so one of the outgrowths of this project was the creation of an anatomically exact ear canal and tympanic membrane and middle ear space designed specifically to test the ear tube insertion device. From this project, we received an additional provisional patent, and we've now licensed it to a company where we feel that this is going to be an indispensable product in teaching residents in otolaryngology training programs how to perform this operation.
The exciting thing for us was that the whole generation of the prototypes and the method of testing it, including coming up with an anatomical model, sort of a dummy head adapted to test our product, that was completely generated by the students. So over the course of 3 years, we've involved over 20 undergraduates on various aspects of the project. And a lot of it, I would say 90% of the new idea generation has really come from the undergraduate students in our program. The advisors, myself and now Dr. Kesser, the ENT surgeon here, are really just here as a support and sort of guide along the way. But most of the creativity really comes from the undergraduate students on the teams.